Hi, everybody. I hope you're all having a great EAGX virtual so far, wherever in the world you're attending from. My name's Bridget, and I'm the MC for this session, which is on identifying the most cost-effective programs to improve mental health with Jasper Synowski and Clare Donaldson. So to start, we'll have a 15-minute talk by Jasper, and then we'll move on to a live Q&A session where we'll also be joined by Clare. You can submit questions either in your name or anonymously using the box to the right-hand side of this video. You can also vote for your favorite questions to push them up higher in the queue, and we'll try to get through as many as we can. Then after 20 minutes of questions, I'll bring the Q&A to an end, but that's not the end of the session. To help you think through and apply the ideas you've heard, I'll be asking you to join a 20-minute icebreaker session where you'll have 2 speed meetings with other attendees to discuss your thoughts on the content. I'll explain how to do that when we get there. But now I'd like to introduce our first speaker for this session. Jasper Synowski studied business psychology before starting his master's degree in public health in Berlin and London. Over the course of his studies, he has interned with various organisations in the profit and non-profit sector and developed a special interest for global mental health, subjective wellbeing, and capacity building. Jasper has been actively involved in the EA community since 2017 and has been part of the Happier Lives Institute since its foundation in 2018. Here's Jasper.
Hello everyone, and welcome to this talk on identifying the most cost-effective ways to improve mental health. My name is Jasper, and I've been a volunteer research analyst with the Happier Lives Institute since its foundation in 2018. Today, I'm going to talk about HLI's Mental Health Program Evaluation Project, or what we like to refer to as MHPEP. A brief outline of what I'm going to cover in the next 15 minutes. First, I am going to talk about why mental health could be considered an important cause area by the EA community. Second, I will shed some light on our research process, really focusing on the process, not so much on results, because we're currently at step 2 out of 3. And finally, I will share some limitations and some lessons learned. So MHPEP, once again, is the Mental Health Program Evaluation Project. And it is one out of several projects that the Happier Lives Institute, or HLI, is currently working on. In case you haven't heard of the HLI this far, it is a think tank that has been founded after EA Global 2018 and is searching for the most effective methods to improve global well-being. The HLI currently has 3 full-time staff members, and in contrast, MHPEP is almost entirely conducted by volunteers of HLI. So we've had more than 15 people contributing to MHPEP over the last 1.5 years, and it's thanks to all of them that today I can share some of our findings with you. At the moment, we have 5 people, 5 volunteers actively involved in MHPEP, plus our COO, Clare Donaldson. If you'd like to know more about the other projects that the HLI is currently working on, then do feel free to ask any questions during our Q&A afterwards. So let me start with why mental health. And as EA community, we like to consider the scale, neglectedness, and tractability of a problem. So I'll start with scale. So the graph that you can see here, some of you might be familiar with. It shows the global burden of disease measured in so-called DALYs, or disability adjusted life years. And DALYs consist of both years lived with disability and years of life lost due to a certain disease or a certain cause. So the size of the different rectangles that you can see here represents the burden of disease attributable to a certain cause or disease. So for example, in the top left corner, you can see heart disease, then you can see diarrhea, HIV, malaria, violence, and finally, you can see that mental disorders account for roughly 5% of global DALYs. There are a couple of interesting things to note here. So first of all, you can see that depression and anxiety are responsible for a large share of these 5%. And just to give you a sense of what that means, it means that 264 million people each year suffer from depression, and 284 million suffer from anxiety each year. It's also worth pointing out that drugs and alcohol, so substance use disorders, are not included in these 5%. Also, it is worth noting that the 5% are probably an underestimate due to several reasons, the most important one being that no years of life lost are attributed in this calculation to mental disorders. And it is also worth pointing out that the impact of mental disorders on subjective well-being is probably not adequately accounted for in this calculation, simply because DALYs are calculated using people's preferences, and people tend to be, or to underestimate just how badly mental disorders affect their subjective well-being. So in the second step, let's look at neglectedness. And again, you can see some data. This time, the blue bars here representing the proportion of DALYs that is attributable to mental disorders in different countries. And these are compared with the proportion of health expenditure that is actually spent on mental health in orange bars. And you can see that in almost all countries, there's quite a huge discrepancy between the two. And this is the most striking actually in low-income countries, where the factor is 14. So just to add to this, it's also interesting to look at so-called development assistance. And so between 2006 and 2016, roughly 85 cents have been spent on each DALY caused by mental disorders, compared to $144 spent on each DALY caused by HIV or AIDS. So third, let's look at tractability. And I would argue that tractable solutions do already exist, and I'll illustrate this by introducing two different programs. So the first one is the Thinking Healthy program. And the Thinking Healthy program uses cognitive behavioral therapy, or CBT, to treat perinatal depression. That is depression that occurs during pregnancy or shortly afterwards in women. And cognitive behavioral therapy has been studied already in numerous studies in clinical settings mostly, and has been proven to be effective in different meta-analyses as well. So for the Thinking Healthy program, community healthcare workers were trained to deliver CBT to depressed women. And this was tested in a large RCT, randomized controlled trial, in Pakistan. And you can see the results here, indicating quite clearly that those women in the intervention group were much less likely to still suffer from major depression at 6 months follow-up and 12 months follow-up, compared to the control group. It is maybe interesting to know that the Mental Health Innovation Network estimates that treating one woman via the Thinking Healthy program costs roughly $10. And it's also worth pointing out here, in case you were wondering, that the control group actually had the same number of visits by community healthcare workers. The difference was just that these healthcare workers had not been trained to deliver CBT specifically. The second program that I would like to introduce is the Friendship Bench. And the Friendship Bench has been tested in Zimbabwe, also in a low resource setting. And it is interesting, especially because it uses the task shifting approach. So the task shifting approach means essentially that specialized services, healthcare services, are shifted from healthcare professionals to so-called lay health workers. So in this case, and as you can see on the picture, lay health workers were trained to deliver structured problem-solving therapy. And this is valuable because through this task-shifting approach, it is possible to address both shortage of specialized health workers and to lower the costs of treatment. So hopefully this has given you a little bit of a flavor of the different solutions that already exist. So essentially, the three reasons that I just presented motivated us to start MHPEP. And additionally, relatively little attention has thus far been paid to mental health by the EA community. So it is currently still unclear what the best mental health giving opportunities are. So as MHPEP, this is what we want to find out. And ultimately, we also want to compare these best mental health giving opportunities to the ones recommended, for example, by GiveWell at the moment. So what has our research process looked like this far? Well, essentially, it consists of three different rounds. First, we have created a long list of programs targeting mental illness, and we've made a shallow assessment of their cost effectiveness. In a second step, we then further narrowed down the number of programs to create a short list. And in the third step, and we're yet to do this, we aim to carry out in-depth evaluations that will potentially result in a list of recommended donation opportunities. So as we're currently still in step 2, I will focus on the first 2 steps in the following. So where did we start for round 1? Well, we started with a database, and that is the Mental Health Innovation Network, which has been mentioned to us by experts in the field of global mental health as the most comprehensive database listing mental health programs. It currently lists 210 programs, and because that seems a bit too much, we then decided to focus on programs targeting depression, anxiety, and stress-related disorders. And we did that because, as you've seen earlier, depression and anxiety are responsible for a large share of the burden of disease caused by mental disorders. And there's also evidence suggesting that they're quite bad for subjective well-being. So through doing that, we got down to 70 programs. And each of these programs was then assessed by 3 randomly assigned screeners using a pre-specified framework, resulting in 25 programs on our long list. If you're interested, you can find all the details on this in our recent EA forum post. In the second round, we then assessed further criteria. And these were, for example, whether the program had been tested in a low resource setting, where we in general assumed costs to be lower, whether there was actually an organization or is actually an organization attempting scale up of the program. This isn't always the case. And we also assessed the evidence base, and we wanted to find out whether there was at least one published direct control trial supporting the program's effectiveness. So through doing that, we further narrowed down the number of programs to 12 programs at the moment. And maybe you're wondering, what are these programs like? So to give you a better impression, we've created this slide, which essentially shows that more than half of the interventions rely on a task shifting approach. Almost half of them rely on some sort of talking therapy. A couple rely on group therapy, a couple are self-guided, and a couple are technology-based, using, for example, mobile solutions like apps. I'd like to stress once again that this is not the final set of recommendations at all. We're still at step 2, and we plan to reach out to the organizations as a next step to carry out in-depth analyses and then be able to make some recommendations. So before I conclude, I would like to share some limitations and some lessons learned with you. So our biggest limitation is probably that we took the Mental Health Innovation Network database as a starting point. So this database has not been systematically updated since 2015, which means that we may have missed out on quite a few programs which have been established or set up more recently. Also, for many programs, the information available on the Mental Health Innovation Network is actually quite limited. So especially in the first round, where we didn't have much time to assess each intervention and completely relied on the information on the Mental Health Innovation Network, this may have led us to exclude some potentially promising programs. Second, we have not considered any macro-level initiatives. So the MHIN lists mostly micro-level interventions, which are based on randomized controlled trials or other controlled trials. And it does not contain many initiatives that aim for example, policy change. So something at the macro level. So for us, this has the advantage that we can compare our recommendations in the future to, for example, the GiveWell recommended programs. But of course, it's possible that we have missed out on highly promising programs. Finally, I would like to share our lessons learned regarding the organization of a remote team of volunteers. And I can really say that over the last 1.5 years, it's been quite impressive how our team of volunteers spread out across different countries, time zones, has been able to collaborate quite productively and effectively. On the other hand, I have to say that this really requires good management, and that even though our progress has been quite steady, it has also been rather slow. So if you're interested in chatting about this afterwards, we're very happy to share our experience in more detail during the Q&A, of course. So if you're curious now, then do sign up to HLI's newsletter. Yeah, we'd love to hear from you if you send us an email, and we would of course very much appreciate your donations to HLI. Also, we're looking for summer interns currently. So if you consider interning with HLI, then please take a look at our vacancies page. So in summary, there are 3 things I would really like you to take away from this talk. First one is that mental health is a large and tractable problem, neglected inside and outside of the A community. Second, a team of remote volunteers, that's us, are currently on the 2nd step out of 3 to identify the most cost-effective mental health giving opportunities. And third, our next steps involve collecting further information from the programs, such as cost data, and conducting more detailed analyses. So here you can find our references for further reading. And I would like to thank you very much for your attention. And I look forward to your questions and some further discussion during the Q&A. Thank you so much.
Okay, thanks so much for that talk, Jasper, and thanks for joining us here now. I'm also delighted to welcome Clare Donaldson for this live Q&A section as well. So Clare joined the Happier Lives Institute as Chief Operating Officer after attending Charity Entrepreneurship's incubation program. She's interned in the research team at Development Media International and helped to lead EA Cambridge. She also has a PhD in geophysics from the University of Cambridge. Thanks so much for joining us as well, Clare. So I can see that we've had a number of questions submitted already, which is really great. Just a reminder that you can keep submitting questions and use the voting function to promote questions that you'd like to see answered. See how many we get through. Anyway, let's get started. So as Jasper mentioned in the talk, the Mental Health Program Evaluation Project is just one of several projects that is being undertaken at Happier Lives Institute. Clare, I was wondering if to start off, if you could perhaps just give us a bit of a high-level overview of the Happier Lives Institute and the scope of work that you've got going on at the moment.
Sure. So we're researching the most effective methods for improving global well-being. And I think probably to lots of people here today, that sounds like lots of us are probably trying to maximize well-being. But often in impact evaluation, it's common to use things like values and QALYs or income as the metrics for impact evaluation. And these are proxies. These are really, really important, but they're probably not ultimately the thing that we care about. So the thing that's different about HLI is that we're really enthusiastic about subjective well-being, that's self-reported happiness and life satisfaction data. And we think this might be closer to what we really care about, and like an exciting metric to use, you know, within effective altruism, figuring out how to do the most good.
Okay, great. Thanks for that, Claire. I guess just coming off that, Jasper, with the evaluation project that you've got going on, what metrics are you using to, I guess, try to quantify the impact of the different interventions and compare them?
Yeah, thanks for the question. So essentially, we have to use data that we have at hand at the moment. So when we're comparing different mental health interventions or programs, we're usually using the standard metrics, which would be, for example, the Patient Health Questionnaire 9 to measure the severity of depressive symptoms, or GAD-7, which is used for anxiety. So that's what we're currently using to compare between different mental health programs. Ultimately, as I've also said during the talk, we aim to compare these programs as well with, for example, GiveWell recommended programs. So that means when we want to do that in different realms and different areas, we of course want to use subjective well-being data. So that requires some other sort of measurement.
Yeah, and I guess that feeds into the broader work that Claire mentioned of HLI, so all coming together. I guess on subjective well-being, one of the questions from Slido that's come up is whether you favour a life satisfaction measure over measures of affect or momentary happiness when thinking about well-being.
Yeah, so I suppose, as I've kind of alluded to, we think, you know, the exciting leap is moving from these objective measures to the subjective measures, and that's what we're most excited about. So life satisfaction is just much easier to measure. It's you know, can be one question or just a few questions, and you can just do the survey quite easily. So there's just a lot more life satisfaction data out there than there is of affect or happiness. So for that reason, I think it's quite likely that we're much more likely to use life satisfaction. And it's an ongoing question for us at HLI and debate more broadly of, you know, if we could get this happiness data, which would we actually like to use? But as I say, I think any subjective measure is like a great step. And sort of broadly, these life satisfaction and happiness seem to go together, at least for probably lots of things that we're thinking about.
Yeah, okay. So it sounds like there are some projects and programs on at the moment that are aiming to create life satisfaction measures. Is there similar projects for for affect measures as well that you know of?
You mean like broadly within sort of research and academia?
Yeah, yeah.
Yeah, I'm not actually too sure. I suppose another thing to mention is that I think economists are, in general, probably more excited about life satisfaction. They think that's closer to utility. But you know, I think a lot of people within effective altruism sort of identify with hedonism, and that's caring about happiness in the moment. But yeah, I mean, it's something we should think about in HLI. Is one impact we could have is encouraging researchers to collect this data more. You know, like asking these subjective well-being questions could be quite simple. That if you're already doing an RCT somewhere, it's not that much extra work to add in some more questions. So yeah, we need to keep working on like making that happen and offering good solutions to researchers to say, you know, you could add this in, and that would be an extra like great data set for us to have access to.
Yeah, cool. There's certainly a lot of work to be done. So jumping into a different question from the Slido app, and I might direct this to you, Jasper. How do mental health issues differ cross-culturally, and how do you handle that issue?
Yeah, that's a really important question, I think. So in general, I think it's definitely fair to assume that the understanding of mental health varies quite significantly between different contexts. What that means is really that any research, any RCTs that are tested, any scale-up that is intended needs to be adapted to a certain, or to the context that this work is being conducted in. So, for example, I spent some time last year in India working with Sangat, which is an organization, an NGO, doing exactly that, testing interventions. for scale up, brief interventions. And really one of my kind of main takeaways was that whatever you're using, also in terms of measuring the outcomes, the kind of questionnaires, all of this needs to be tested first through qualitative research, usually within the specific context you're looking at. And only then it makes sense to talk about mental health. So definitely what we cannot and should not be doing is try and take a one-size-fits-all approach and try and, fit this to very different contexts.
Yeah, okay. I guess another question, probably I'll send this to Jasper initially as well first, and also Claire, feel free to jump in at any time if you've got any comments. What do you think about the proportion of mental health problems in low-income countries and perhaps even also just broadly that can be solved or improved by non-mental health interventions? So the example in the question is, for example, preventing domestic violence. And I think this also links to another question which has been posed, which is, I guess, about the relationship between mental health and physical health, and I guess the impacts of improving physical health on mental health, and or vice versa.
Yeah, again, really interesting question, important question. So I think, well, it's some of you might be familiar with like the causal concepts, which are currently used or mainly used in epidemiology. And so many people tend to think of diseases or disorders as occurring by means of different causal aspects that come together to then have a certain disease, disorder occur. So this certainly applies to mental disorders as well. So there are so many reasons to take into account. It's really hard to kind of give a number of a fraction. I don't think I could do that off the top of my head reasonably. But I think in general, there's probably a considerable proportion that could be prevented through non-mental health programs or interventions. And I think especially domestic violence is a topic that has been on the agenda now more recently, has become more attention, and of course is very closely intertwined with any mental health discussion.
Yeah, okay. Claire, was there anything you wanted to add on that? Or? Yeah, well, you mentioned, Jasper, that it's hard to pick a number off the top of your head. It reminds me of thinking back into your talk where you mentioned that the mental disorders, the global burden of disease doesn't include any deaths in that figure. There's nothing there. And that's partly because it's really hard to tease apart these comorbidities from different diseases. If someone's died from a heart attack, their depression may have played into that, but it's very hard to tie that in. So methodologically, it's just very tricky, and I think the people working on the global burden of disease are trying to work on that, but it's tricky. I mean, another interesting part of this question is the relationship between mental health and poverty. There's a nice sort of really easily readable meta-analysis that's just come out, which I can send to people in Slack by Ridley et al. Looking at the sort of causal effects both ways on how mental health affects your income, but also if you were to receive some money like a cash transfer, how that acts on your mental health, and how that these things go both ways, and sort of teasing apart that relationship is it's difficult, but that's in this paper where RCTs are helpful.
Yeah, okay, great. And I'm just interested, with the comments you made about the global burden of disease study, Claire, if you could give some advice to the people that are running the GBD that would, I guess, help it to better, I guess, quantify and represent the impact of mental health disorders. Do you know what that would be? That's a hard question.
That's a hard question. I'm flattered you think I know the answer. Well, I mean, I suppose the only thing I would say is that it's done in DALYs, and just to bang on the same drum, but DALYs only captures one aspect of mental health. You can only have an aspect, you can only have an impact on valleys if you have a disorder like depression. So if you're just suboptimally happy, but you don't necessarily have depression, that's just not accounted for in the global burden of disease at all. That's, you know, so we're kind of missing a huge aspect of what makes life go well for people by only relying on that sort of one part of it.
Yeah, unless they've updated it recently, and unless I'm wrong, my understanding is that the disability weights come from asking people whether they think a certain set of symptoms is healthier than another. And I think that the use of the word healthy can be difficult in that setting, because there might be some things that we think are important from a health perspective, but we wouldn't necessarily think that people with that disorder are unhealthy.
Exactly.
Yeah. Okay, cool. So another question from Slido that has quite a few upvotes is about the use of psychedelic medicines, so like MDMA and psilocybin, to alleviate mental disorders. And it is something that gets talked about a lot in mental health, and there's a lot of excitement about. What do you guys think of that? Should this be something we should be investigating more, or do you have an update on the research in that space?
So I don't have an update on the research. My understanding is that there are some, you know, really exciting initial results that look like for treatment of things like PTSD, psychedelics look very exciting. I think there are big trials underway, and I suppose personally I'm sort of waiting for those results and see if it really comes through when we test them at a big scale.
Yeah, seems like a reasonable response to wait for the research. Very sensible. So I guess another question, which I'll direct to you first, Jasper, but then I'd also be interested in your thoughts, Claire, is why you think mental health interventions might have been neglected in the EA space previously.
Yeah, so I think mostly really the EA community over the last years has, at least in terms of global health, mostly relied on the kind of conventional metrics that we've, touched on already, DALYs and QALYs. And I don't know if any of the listeners has seen the Founders Pledge report, for example, that estimates the cost effectiveness of Strong Minds, which is one kind of mental health program we're also looking at the moment. And they're still using the kind of standard framework. And through that lens, it could be argued that mental health interventions broadly do seem less cost effective than, for example, the classic BedNet intervention supporting AMF, for example. So I think that might be one of the reasons, really. But I think it's also fair to say that not only within the EA community, but globally, the topic has been neglected really over the last decades. And I think the reason why it's received more attention now has to do with also public debate that is ongoing now.
Yeah, just to add, I think you're completely right, Jasper. Lots of the sort of academics I've spoken to have, really reflected on that it's only over the last, decade or two that we're starting to really pay attention to mental health. It seems like it's just something that's been neglected more generally. And yeah, I guess I think that makes me kind of excited about it as a cause area, that global mental health is, to me, it seems like a kind of younger field than sort of global physical health. And yeah, I think I'm sort of hopeful that if we're in effect altruism thinking about this sort of now, that maybe it's an exciting time to start new projects or steer the sort of area in a way that sort of aligns with effective altruism. And yeah, I think that's kind of an exciting thing about mental health. It's just a younger field.
Yeah, I think it's a really good point. That being a younger field, it might be a bit easier to steer it in a certain direction.
Potentially, yeah.
Yeah, cool. So I guess related to that, there's a question here asking about what an individual or a small group might be able to do to help work on this yeah, do you have any advice or suggestions? I'll go to Jasper first.
Okay, cool. So I'm afraid I cannot point out very concrete recommendations off the top of my head, but I would generally recommend trying to talk to as many people in the field of global mental health, listen to their experience, and try and find out what these people who've been involved over several years think are the most pressing kind of things to work on at the moment. That would be, I know that's very general advice, but maybe Claire, you have something more specific to add.
Yeah, well, and I suppose something that this project MHPEP is, you know, I think it's such a wonderful thing about the Effective Altruism community is that a group of people met at EA Global in London. They wanted to do something, and they got together, and then they've done it, and carried on doing it, you know, today. So I think if you're listening to this and you're inspired, you know, you can do that too. Connect on Slack with people at this conference. You know, there's a mental health and happiness Facebook group you can join. There's lots of ways, and I think it is possible to, you know, do a research project and do some impactful research. So again, it's not specific, but you know, I would really encourage people to try and find something like that.
Yeah, okay. So I guess being aware of what's going on and also reaching out and making connections.
Yeah, of course. And you know, do email us. We'd love to hear from you.
Yeah, and I believe on one of your last slides, maybe the last one, Jasper, you mentioned that HLI was looking for summer research interns. So maybe that could be something that people could apply for as well if they're interested in getting more involved.
Thanks for reminding us. That was something I should have said.
No worries. So we are getting towards the end of our Q&A session. So maybe just as a kind of wrap up, I'll give you both the opportunity to, if there is anything that you're wanting to say or wanting to communicate, an open floor to do that. And also, Claire, if you could perhaps maybe just give us an idea of the goals for HLI in the next 12 months and where you see the organisation heading. So over to you, Jasper, first, and then finish up with Claire.
Okay, cool. Yeah, I guess I just want to say thank you very much for listening, for caring about this, and for wanting to know more. I'd like to once again stress that we have this EA forum post out there. We've posted it, I think, 3 days ago. If you're keen to learn more about the MHPEP, then that would be a good way to know more. And otherwise, of course, feel free to reach out anytime, and we're very happy to chat and connect.
Yeah, I suppose I'll just tell you a little bit more about the other projects we're doing, as perhaps I haven't told you enough about them. So I think our research agenda is fairly broad. It's a mixture of theoretical and applied research. This MHPEP is at the applied end, but the theoretical work is sort of touched on earlier with which measure of well-being should we use. We're sort of working on that and the theory behind that, thinking practically, looking at validity and reliability, these kind of questions. And then maybe our main research project this year is sort of straddling these two things. We're looking at different interventions and trying to assess the impact in terms of subjective well-being. So it's kind of what I've said we're all about. We're trying to actually do that and see how it works in practice. We started by looking at cash transfers, and then we want to look at some physical and mental health interventions. And what we're really interested in is, how do our priorities change when we use this metric? You know, does this actually throw up new things we don't realize? And on the practical side of things, like, you know, how much data is there? What are the sort of bottlenecks in actually using subjective wellbeing in impact evaluation? So I guess I hope in the next year that we have some kind of answer to that, and that will sort of steer our research in the future. You know, I think HLI's path is somewhat uncertain. If we're going to, you know, which way are we going to go in this sort of theoretical to applied spectrum? but we're trying to take the scientific approach and test out different things and learn from it, and hopefully we'll have the path of highest counterfactual impact in the long run, and hopefully we'll make lives happier along the way is the goal that we're all about and we're trying to remember.
And it does sound like a pretty good goal. So Jasper and Clare, thanks so much for joining us here, and thanks also for the work you're doing with HLI. It's been really great to learn a little bit more about it and to hear from you both. So that's all we've got time for this Q&A session. But everybody at home as well, not just Jasper and Clare, don't go away just yet, because discussing new ideas with other people can be a really good way to understand them. So we're going to use the last 20 minutes of the session for a couple of short speed meetings with other attendees. If you check the session description below this video, you'll find a link to an icebreaker session where we're going to gather for those meetings. So please click on that link now, and a new host will meet you on the other side. Okay, thanks very much for joining us.